We've got three individuals that I have the pleasure of knowing pretty well. And what I'd like to do is to allow them to really introduce themselves and talk about their background. And we will start with Dr. Mark Kestner. Please, could you introduce yourself?
I was hoping you'd start down there. I'm Dr. Mark Kestner. I was a trauma critical care surgeon for 25 years. I've been doing healthcare administration for about that long also. Got out of clinical medicine about 12 years ago. I have focused on, I like to say, innovation in healthcare, and to that end, I've implemented telemedicine in at least 5 different health systems across the United States. The driver for that was based on the market, right? In New Mexico, it was scarcity. In Nebraska, it was an EICU covering 10 hospitals. In certain health systems, it was the health plan that drove it. And in other systems, it was a scarcity model, such as the Central Valley of California. So I'm really happy to be here today. You guys are sort of on the cutting edge, and it's going to be interesting to hear the conversation over the next 2 days.
Thank you. Dr. Chris Veremaks?
I'm Chris Veremaks. I'm an intensivist. For the first 25 years of my career, I ran a critical care department in a 1,000-bed teaching hospital in St. Louis. We did all the adult critical care, medical, surgical, and neuro. And I had a particular
Breakfast just kicked in.
I had a particular interest in neurocritical care. And in 2006, our head of innovation for our health system, which covered 30 hospitals in 5 states, came and said, "What do you think of tele-ICU?" And those of you who were here last year will remember this. I said, craziest thing I've ever heard of. You cannot take care of critically ill people from 250 miles away. Well, in 2006, we opened our first tele-ICU. We spread it across 16 hospitals in our 5-state region. We've since expanded and are covering over 500 ICUs in 5 or 6 different states. And I slowly moved from 2006 to 2008 from my old position, which I was very comfortable doing, into this new position in which all we did was inpatient telehealth. We opened up a telehospitalist program. I tried to get neurologists across our health system to do a tele-stroke program. I was met with not apathy, but hostility. That's how I developed the relationship ultimately with SOC. We now have a telestroke and neurology program up across all our facilities. There's a facility in the Mercy Health System, and I think we're at 31 or 32. When my microphone is coming on and off, it seems like, in which we deliver stroke care. And then we've since added inpatient pediatrics, a lot of specialty care in both the outpatient realm and inpatient realm. I focused on inpatient care because that's where I've been from the very beginning, and we have a whole other group doing outpatient medicine now.
Okay, thank you. And Brendan McNamara, could you please introduce yourself?
Absolutely. Good morning, everybody. My name is Brendan McNamara. I am the CEO for the telemedicine service line of Sound Physicians. I'm relatively new to Sound Physicians, only in the past 5 months, and I joined specifically to build up this entity within the organization. All of my career has been in healthcare services. I have helped launch wholly new businesses with venture or private funding, or tried to launch businesses within larger corporations, entrepreneurship. I've got a sort of diverse career that has spanned working with acute providers, post-acute providers, the pharma space, and my last job before this was working for Anthem, the health insurance company. So certainly can relate to the payers' continuing focus on post-acute spend as an unmanaged spend as of right now. And Sound set up our telemedicine service line as its separate business, a startup within the entity because we saw what a huge opportunity this was. So we really think about two segments of our business. There's an opportunity to support Sound's core hospitalist medicine business and work to create more innovative or cost-effective delivery models of our core business, which is providing hospitalist medicine, emergency medicine, or critical care medicine to our hospital customers. And then our other great focus and where we are super excited about is that opportunity to expand outside the four walls of the hospital and being able to leverage the physician practice that we are, the capabilities we've built over time, and leveraging technology, be able to use those physicians to improve outcomes in the post-acute setting.
So as you can see, when we think about the topic that we want to discuss right now, which is where is telemedicine headed? What's the future of telemedicine? The experience that's sitting here is really, these are the relevant folks to have this discussion with. So we're really thankful to have the three of you here. But let me kind of start out by talking about standards of care. So one of the things that I'd like to mention is 15 years ago, in the Journal of Telemedicine and Telecare, there was a whole article and description about where they felt telemedicine was headed. And one of the things that they said in that article was that we see telemedicine getting embedded in the acute space and then certainly going to post-acute and even the home. And the other thing that they outlined was the physician shortage. Because of the significant physician shortage that we're feeling, especially in some specialties, they felt that innovation would be pushed specifically through telemedicine, and it would really make telemedicine embedded and be just part of the natural healthcare system in the US. So the question that I have, and I'd love to see if we could start with you, Brendan, on this question, is where are we in terms of that vision? Where are we today? And where do you see us, let's say, in the next 5 years in terms of that shortage, the innovation around telemedicine, and embedding it into not only acute but post-acute?
So, I have two minds a little bit of it. Is, in one aspect, Sound has made a very specific strategy around thinking about and including telemedicine within our care teams. Thinking of it as just another extension of that care team. So thinking of it as a core foundational aspect of how we deliver care within our hospitals. And so to that extent, we think of it as part of the standard of care. We want it to feel natural. We want the hospital to feel that this is a natural extension of our team. We want the teams to think of it as a natural extension managed in a very similar way, et cetera. So from that perspective, I think that we sort of have achieved where it can be the standard. On the other hand, as you mentioned, that article is from 15 years ago, right? We all know the pace of change in healthcare is extremely slow. And so there are still challenges. That is still change. And we still face internally and then with some of our hospital customers that challenge of adoption and making people comfortable with this change. But I think the pressures are moving, pushing the systems to embrace it, and we are increasingly seeing that adoption over time, but it's a little bit.
Are we past the tipping point?
I think we are. I do think we are. For sure. Personally, okay. I believe that.
Dr. Kestner, would you add?
Yeah, I'm sort of jaded because I don't think healthcare is not very innovative, and I don't think the pressure is going to come from healthcare. When you look at the evolution of healthcare in the United States in the mid-80s or 1800s, people went to hospitals to die. And then somehow, during the 1900s, people went to hospitals to get well. And I think the consumer is now looking at hospitals as a place to die. Okay? And increasingly, I think that consumers are going to expect that they can get their care at home or they can get their care on their phone. And that, I think, is what's going to drive the change within physicians and nurses and health systems. I do think that there's a tipping point. I look at my kids, they're in their 30s. They abhor going to an emergency department. They don't want to go to an emergency department. They want to go to CVS or they want to go to their phone. Increasingly, I think the acute care, the person that gets stuck going to a hospital is going to expect to get out of that hospital quicker and to have the tools available to them at home. And I think there are areas in the market where that's already occurring. So I think we are hitting the tipping point, and we'll get into this, but I don't know that the government and the financial models have caught up to that quite yet.
Well, that's always a good discussion when you can have a little disagreement, right?
Exactly.
Do you want to break the tie?
Yeah, well, I like the three buckets you talked about in terms of pre, acute, and post. Again, the millennials clearly, in terms of pre-care, want it simplified. They don't want to have to go to a doctor's office, and I understand that. I think being an
Dr. Veremaks, we're going to give you a live mic because there's something going on with that one. So, Meg, if you would just please, and let's make sure, please, that his is off, okay? So we don't get the background.
Is that better?
No.
No.
It's you.
And you're supposed to break the tie.
Yeah.
I'm a curse.
Test.
That one's working. Yeah, I heard it.
You did?
Yep.
There you go.
Okay.
All right.
Much better.
I've seen a huge change in the acute care world, which is where I live. People didn't think they needed it in any way 13 years ago, and now they recognize there's all sorts of needs they have. In some ways, I think the mistake we made was that we came in saying, you know, we've got this great thing, and it's going to solve problems that they didn't even think they had, and we imposed it on them. What we've gotten more used to is partnering with our customers, which takes time and relationships to find out what their problems are and help them solve things. And I think that's the tipping point for acute care medicine now. I think all our hospitals want help in the acute realm. It's just a matter of making sure that you're both on the same wavelength, and you don't have a solution to a problem they don't think they have, and you are addressing the problems they do think they have. So for us, things like sepsis programs across the entire hospital, not just focusing in tele-ICU. We took the concept from tele-ICU but applied it to the entire hospital. Suddenly now we're helping these hospitals with their sepsis programs and making it work. And I might also emphasize, I don't like to use the term telemedicine so much anymore. That implies just that interaction across video, which is a part of digitalized medicine. But we have a whole sepsis program in which there's never any telemedicine going on, but we are monitoring 18 different hospitals from a central place in St. Louis, and all the data's coming in, and we're pouring through it, and we're weeding out false positives and false negatives, and then notifying the bedside when we know we have a real issue, and then we can either help them with their problem if they don't have the resources to do it, or if they do have the resources, we've notified them to take action, and then we monitor what's going on. That's been a tremendous help to our hospitals. They appreciate it, and it's an example of a more broad notion of telemedicine, and I think that's where we've succeeded in changing people's attitudes towards what's going on. And then I'll just add, then there's the post-acute world, which is, and I'm an inpatient physician, but I recognize that's where the big bucks are, that's where the need is, and we think there's going to be a big move into the post-acute world, but the economic incentives have to get aligned.
Absolutely.
Because right now, when I go to a hospital and say, guess what, I'm going to keep people from being admitted to you, they don't really like that because they make their money off of admissions. So when I tell them I'm going to cut their admissions in the next year by keeping people in their homes and taking care of them there, they're not really on our side about that. So the economic incentives have to get aligned to make that happen.
Yep. So I'm going to be an opportunist here, and while the mic is working, I'm going to ask the next question of Dr. Veremaks also, right? So before I ask that question, let me share some stats here that really are alarming. rural communities, and we're going to talk about rural hospitals and communities, make up 20% of the US population. But the access is to 10% of the providers in the country. So there's an imbalance there. Also, there was a research report by Pew Research Center that said nearly a quarter of the rural residents, if you ask them their biggest, most major concern, they said it's access to doctors and hospitals. And we don't see this getting any better. Where we are dealing with communities, we see the struggle of specialists making it out to a lot of these rural communities and driving a great distance to be able to get there. And to top all of this off, we see rural hospitals closing at an alarming rate. So with that kind of environment, can you talk about telemedicine and how it can help those rural communities? And again, the future question, where do you think this will be, this model for rural communities will be in 5 years?
So I think we're moving, and telemedicine is helping us move towards team-based care. So you're now going to have teams of which physicians may be the leaders up top, but the actual providers are going to be advanced practice people of one kind or another. I think that's one of the solutions to the rural area. I will tell you about our rural hospitals in Oklahoma. We have they can't find hospitalists. Mm-hmm. And the local community doctors, I was shocked when I found this out, they don't care. They're not going to go to the local hospital. They just as soon send their patient 80 miles to the larger hospital because they want to just stay in the office. And what we've ended up doing is you have to have state regulations that allow this. APs in our emergency rooms and as our hospitalists, and our large hospital has a telemedicine arrangement with those facilities so that the physicians can be available to support the APs that are the hospitalists in those hospitals. They can round on the more difficult patients, and one hospitalist can cover 3 or 4 of the smaller rural hospitals, and in that way you've got a service in those smaller hospitals that functions well. The community trusts that model, and in fact the admissions to those local hospitals have increased since we've put that type of program in. Now, you have your hospitalist in place, but now, of course, you need the specialists too. So you've got to add the specialty consultations that may keep those people in the hospital, and that way keep people in their communities where they'd prefer to stay and get their treatment in the communities, and only transfer people to the tertiary hospitals that absolutely need that. Of course, again, you've got a problem because your CEOs of your tertiary facilities are used to getting all these people sent to them, and when you tell them you're going to decrease the referrals from some of those hospitals, they're not totally on board. And that, again, is where you've got to function not as individual units, but as a whole health system, looking at the welfare of the entire health system. And that's a big change in mindset for people who have been used to functioning just with individual units and budgets and revenues and success defined just as how their individual unit functions. So those are the things that are resistant to that. But I think that's the way the future's going to look.
Yep. Anything to add to that?
Yeah, I was here, I think, last year, and some of you may have heard the talk I gave about Fresno, California. That was in my former life. And if you have an hour to sit and talk to me, I'll tell you what I'm doing now. But the bottom line is that in Fresno, California, in the Central Valley of California, there's only 50 physicians per 100,000 patients. The national average is well over 200 doctors per 100,000 patients. So they only have a quarter of the physicians that they need to deliver the care. The hospital that I was the chief medical innovation officer, went there as a consultant and helped them with their throughput, had an ER that was 100 beds, and their average daily census in that emergency room was 150 to 200 patients. So I used to tell my wife, because I lived in Scottsdale at the time, that I'm going to Fresno to do God's work. because there weren't people to deliver the care. That being said, the mindset of the administration, and I'd say that if they were in the room, was heads and beds, right? And there were a lot of innovative things going on in California with regards to at-home care, but nobody would pay for it, right? They were willing to bring social workers out to the house to decrease readmission. Well, who should pay for that, right? I need the patient to be in the emergency room if I'm going to charge for that care. So I think we're at a tipping point in the US, in the rural communities, where the economic model doesn't fit anymore, and we're going to have, and the consumer as well as those small communities are going to have to change. I think the other thing that's sort of interesting about California, and I'll just mention this because I've studied it recently, they have the corporate practice of medicine in California where you can't employ, hospitals can't employ physicians. And the rural hospitals are closing because exactly what happens in Oklahoma, you can't get a physician to go to those rural communities unless you subsidize their care or subsidize their income. Most recently, the state has said, we'll give you a waiver, but the waiver's for 3 years. So they guarantee a physician's salary for 3 years, and then what happens after 3 years? The physician moves on. So again, the whole economic model or our mindset with regards to expanding our footprint in the market isn't working, and it's going to have to change.
Brendan, did you want to add to it?
I think those are fantastic answers. The only thing I would add is I think you can sort of connect those first two questions when you think about the adoption of in the post-acute setting or in these rural settings. I think telemedicine is a demonstrable improvement over what's there today, right? They have a lack of physicians, or there's just no physician coverage, et cetera. It's a clear and market improvement, and that helps adoption of like, this is better. I think in the acute setting, there's still some who resist and think of it as lesser, right? I think many of us would argue that it's not, but that's the conversations that you might be having with, I had a doctor in person, and now I have one by video. That feels like less, whereas in the post-acute community and in the rural communities, it's demonstrably better, and I think that really supports the adoption and gives us a great chance to leverage technology to solve some meaningful problems.
Very good point. All right, so with all of this, though, one of the things that we're talking about is the physician shortage, and the ones that remain, burnout, right? So why is burnout increasing? We see it in terms of additional demands, in terms of documentation and analytics on the physician, especially with the advent of EMRs and all of that documentation. We've seen that burden. We've also seen a burden in terms of the growing aging population in the United States and the lack of enough specialists coming out of medical school to really support it. So as we think about this, I'd like to hear from the panel on helping physicians with that burnout and improving the physician engagement, which is really critical, right, to support the healthcare system. So, Dr. Kestner, can we start with you on that question?
Yeah, so this is an editorial comment. Sorry.
He's very shy.
Yeah. The company I work for right now is in 40% of healthcare systems in the United States, and one of the product offerings we have is privileging and credentialing. And the reason and enrollment. And the reason I bring that up is, do you realize that what a physician has to do in order to be recognized by a health plan when they come to a community? Mm-hmm. It takes 3 to 6 months for them to even begin to reasonably bill. So again, that administrative burden, the state licensure problem, the insurance problems, if you're running a private practice, that becomes your issue. If you're part of a group practice, it becomes a group practice issue. Somebody is blaming the physician for failure of that system, and I think that's grossly unfair. So we have the ability to streamline some of those processes and engage physicians in liking what they do for a living. I like to use the example, I've been privileged and credentialed in 11 different health systems in my career, and it takes an average of 3 months to 6 months for you to be recognized by a health plan. So for 3 years of my professional life, I was in professional limbo where nobody believed that I was a trauma critical care surgeon and you were going to pay me for my services. And so that's a huge problem. And I think until we start to address issues like that, we're really not going to be able to engage physicians and practitioners in their love of the practice of medicine. The last thing that I'll just mention is there's been a recent law by the federal government that they will not pay for discrepancies in the physician identity to the PACOS database. So if I generate a bill and I use in my bill ST as street and the PECOS database has me as STREET, they will deny payment. So again, that is a ding against me as a profession, and that I'm not getting paid for my services. So I think until we start to align these things and stop making it a game for physicians and providers, those are the things that we need to address, core issues that I think we need to address in order for them to be engaged.
Thank you. Dr. Veremaks, anything on the physician burnout topic?
Yeah, well, one of the reasons I was a hospital-based physician and an employed physician my entire career was I didn't have to want to deal with that.
Exactly.
Kind of stuff.
Talk to my wife.
But I worked lots of hours, and so the burnout issue, I mean, clearly we've got a generation of physicians now who believe more in a work-life balance, and we have a shortage of physicians. Those two together translate into even a greater shortage coming up. The frustration I hear from our younger physicians is that they spend too much time not practicing medicine. They either are, they're in the computer, the computers, the EMRs were supposed to help us save time, but in fact, you spend an awful lot of time in documentation, either for billing or for healthcare reasons or for data analytics. You spend an awful lot of time in the EMR in documentation, and it makes physicians more inefficient. An awful lot of the young physicians I know go home and then do notes from home because they didn't get a chance to do their notes during the day. So I don't know that there's a solution for that, but that's part of the burnout issue. Now, again, just very a microcosm, what we've tried to do for our young physicians is emphasize how the telemedicine helps them with that work-life balance. During the first 20 years of my career, when I was the attending physician in an ICU, I worked for 10 or 12 hours during the day and went home and took all my calls on my ICU for the whole week I was on. Now, if you ever suggested that the attending go home and take all their calls, it would not be sustainable. But our tele-ICU, which is an extension of that practice, takes care of those calls. So in many ways, we support the physicians on the ground by protecting them in off hours, helping their work-life balance and addressing burnout, and that's a way that we can build sustainability. I use as an example a hospital in Northwest Arkansas where they could not keep an intensivist because they'd burn them out, and they couldn't keep neurologists because they'd burn them out. Once we put a tele-ICU in place and our stroke neurology program in place, so that when they went home and weren't bothered. Now they've kept those few specialists they have on the ground, otherwise they wouldn't have them at all. And that helps the communities, it keeps specialists in the communities, but it protects those few specialists from trying to practice 365 days a year, 24 hours a day. So I think telemedicine in that way can help with the burnout issue. I think whoever was in control of the educational programs in this country, there's an enormous number of people who don't get into medical school each day because we have a fixed number of slots. We did not anticipate the requirements for physicians and nurses, and now we have this incredible shortage, and that's not going to go away.
Mm-hmm. Can I ask a follow-up question related to the financial models? So if we think about the financial models today, we're talking about post-acute. We're talking about sending people home and taking care of them there. But if we really look at the reimbursement models for that, they're really not formed at this point. Mm-hmm. The other thing that we see a lot is that, home care itself, we're forcing that patient to come back into a hospital setting because of that reimbursement imbalance, especially in certain specialties. So Dr. Veremaks, if I could follow up and ask you that question, how do you see that model changing in the future to accommodate virtual care?
Well, so you've got to work with the payers, and the payers have to be willing to agree that there's money to be saved, but they can't keep all the money, that they have to partner with the health systems to share the money. Because very clearly, if you can deliver a bunch of care in the home, it saves the payer substantial amounts of money. But they have to share that to help fund the program. Some of the incipient programs we have in place now, frankly, our health system is eating the cost, hoping that with the proof that it can decrease acute care utilization and keep people in the home and deliver their care at a lower cost. They're hoping that the payers will see this and then be willing to cut contracts in the future that share the money that's saved.
Absolutely.
But that's what has to change in the system, and the payers have to be willing to share the savings.
So Brandon, you know a little something about the payers' view on this?
Yeah, I think you've captured it very well, and I would say, I do believe that payers are getting more innovative in sort of how they think about these things and willing to think about sharing and how they can sort of, in a pie that is being squeezed on all sides, are becoming more aware that they need to create more innovative payment models to help the healthcare ecosystem succeed to reduce cost. And I think you certainly see that in post-acute. And then there's also this integration between payers and becoming providers is moving in that direction as well in terms of trying to create their own system of economics that allows the sort of cost savings associated with innovation accrue to the payer. So I think there's
Movement in the right direction?
definitely, again, it's slowly, and I think they're large organizations, and anytime there's large organizations, even just like a hospital has to think about the health system all combined, not the rural hospitals, not just the acute settings, et cetera. The payers are the same way, right? There's different pieces of the organization that are looking out for their own good, and the more that they can see across the organization for the greater cost savings, the better off they'll be.
You don't have a view on this, do you?
Yeah, I'm not going to disclose my political bent, but the word payer sort of gives me a visceral response because I don't think that they're in the business of delivering health and healthcare to a large degree. I don't need a subscription to silver sneakers, I think is the latest thing I've seen on TV. I think we have to sort of change the idea of what health means to a community going forward. I think there's a lot of things that are occurring that are pushing us to population health and population reimbursement, but I'm concerned that the third-party payers aren't going to be the drivers of change. And so then what we're left with is potentially the government, which isn't a great option, or the community at large, people in the community at large expecting to stay healthy. So I don't know what the right answer is. I know that we're trying to do a lot of things to sort of cover our costs, but we're trying to cover our costs in an extremely inefficient and overpriced model of care, and we can't afford it anymore. So I think it is going to change whether we like it or not, and in some of that it's going to be denial of care, but I'm not sure that it's denial of care versus just keeping a population healthy that'll get us out of this.
Okay.
So I like the idea of having the community speak up, and I think we are. Just a point that just dawned on me. 10 years ago, when we would be having this conversation, one of the first things that would come up is, will the people accept it? Will the older people accept it? Will an older person wants to see their doctor and they're not going to get on computers to get their health care? Well, that's how much has changed in 10 years. The older communities love telemedicine. The people that we treat in their homes, they develop relationships with the groups that come in and see them. They love staying in their home and not having to get up and go to the doctor's office. They are embracing this, and maybe that's the community we have to get to speak, because for them this is better care, it's more convenient care, it's more frequent touching of those patients, which translates into better care, and it's saving a bunch of money. And that's how much things have changed in 10 years that we can now say that.
Yep. I'd like to shift the discussion to future specialties, right, and adoption. And Brendan, if we could start with you, because in preparation for this panel, you expressed passion around this topic. So where do you see that adoption going? Which specialties? What location of care? We commented a little on this, but can you expand on this?
So, from my perspective, I really focus on locations of care from a population health perspective, and I do think that's where we can really leverage telemedicine. I think that at Sound we're very focused on skilled nursing facilities and how we can improve the delivery of care in skilled nursing facilities that often have a great deal of variation in their physician coverage. They have call models, et cetera, which is really just suboptimal, and we see significantly suboptimal results, clinical outcomes from those settings. But then increasingly we think about how can we help in the home in the same way you described it. I think that home-based care, which I differentiate slightly from home health as kind of defined by CMS, but I think what we're increasingly seeing home-based care evolve, and higher acuity patients trying to stay in the home. And I think telemedicine is an incredible opportunity there as well, especially with growing and ever-increasing remote patient monitoring capabilities, et cetera. I think you really can create the clinical model has proven that you can treat a huge percentage of patients in the home with improved outcomes. I think it's about figuring out the economic incentives, to align the resources to really to make that work at scale in the marketplace. So the more we can keep patients outside the four walls of the hospital, I think the overall system would be better off.
So Brendan, I started off saying the same exact thing. So I agree that shift is there to the post-acute. Do you guys disagree, or do you agree with that? And also the second part of this is, what specialties do you see moving into telemedicine? It started with stroke, and behavioral health is really big, and critical care is big, but where do you see the adoption and movement? So Dr. Kestner?
Yeah, I think there's money to be had in the post-acute, and the federal government is starting to see that in their bundled payment methodologies and utilizing at-home care delivery models. And that's, I think, changing public perception. I think the other thing that's been a huge boost to us is the opioid crisis, where people start to realize maybe staying in a hospital and taking narcotics isn't the best thing for me. So I think there's a public awareness that is changing to the post-acute care delivery model, and I think that's only going to grow. I think also that the readmissions, people give lip service to readmission rates, but I think increasingly there's going to be pressure on healthcare systems to address those issues. And again, post-acute visits are going to be a solution with regards to that. As far as specialties, I agree with home care and people in skilled nursing facilities. The problem right now is the economic model still incentivizes that facility to send the patient to the emergency room if there's a problem. And we have to sort of address that issue. But as far as other hospital-based specialties, I think there's a huge opportunity with infectious disease. Everybody has to have a antibiotic stewardship program, and what you describe with ICU is no different than antibiotic stewardship. And there aren't enough infectious disease doctors in the United States to cover that need. And really all it is reviewing and looking at data and then raising flags. I think the other thing that where we can save money in specialty care is prison populations. There's absolutely no reason why they need to be coming to the hospital. They can be cared for in prisons, and that's not being selective. But I think that, and then I also think psychiatric services. I think there's a huge growth and need for that in the community, and I think that people will start to recognize that that is a productive way for us to address that crisis in this country.
So I'd like to, the last question that I really want to ask before we end this and see if we have time for questions is really about technology in the future. You know, we hear a lot about artificial intelligence and big data. Everybody's heard those terms. How does this impact care, and what does the environment look like, and how are we going to use artificial intelligence and big data? And I'd love to start with you, Dr. Kestner.
Yeah, you know, this is a favorite topic of mine. I think,
that.
yeah, I know. I think the thing that we have to start to come to grips with is that we really don't need as much clinical data as we thought we needed. When you look at what people need to carry on their Fitbit or their iPhone with regards to their health care, it's, you know, their diagnoses, their medication list, you know, their last admission. So it's family history, but it's simple stuff, right? And we have to be able to get that has to be accessible to the general population. If I want to know what my prescription history is, I have to go to my PBM and request for a report, and that can take about 6 months. They don't have to give it to me right away. And that's my information about me. So I think, number one, I agree with big data, but I think we have to simplify the information that we think we need. I think the other thing is I've been very impressed with the artificial intelligence that lays on top of data to mine it. But again, I think the people that are doing that have to simplify it versus making it complex. And I think that the answers are there. But I think the people that are looking for the answers are making it a bigger deal than it really needs to be.
Interesting. Brendan, anything to add? And then we'll go to Dr. Veremaks.
Sure. So one of the roles that I had at Anthem was the strategist for their in-house analytics group. And so I am, I think, a little bit of a contrarian in this in terms of the utility that we saw from the new and we had a 50-person data science team and AI and all that stuff. You would find innovative ways to perhaps reduce the cost of care, but it was at the margins, right? Like it's another percent here, it's another percent there, and I think realistically in healthcare, I hate to say it, but there's still so much obvious things that we don't get right, or we don't share data across teams that need it, some obvious stuff, that to me the solution is not, we're still a step away from from new analytic techniques or technology really moving the needle when some of it is right there in front of us, right? It's
basic blocking and tackling.
Yeah, it's just
right?
sharing the information from the nurse to the doctor effectively or across shifts, or all those types of things. Realistically, that's what makes the big change, the big opportunity for improvement, and the rest is the marginal change on the top.
Yeah, the company that I'm with right now, we have 15 million contracts in our database, and a third of those are physician contracts. And the insights that we get out of the analytics are simple things like you're paying this physician to be on call and he doesn't have privileges at that hospital. Yeah. Or 3 years ago, you changed your policy with regards to cell phone usage and you're still paying him for a cell phone.
Or you that's the contract.
Yeah, or you renewed the contract and, oh, by the way, they're no longer in the system. But, it's simple things like that. So I think we're overthinking and we're leaving the basic stuff on the table because we just are thinking that that's too simple. Well, it is simple.
Dr. Veremaks, can we ask you for the last word?
Yeah, I would agree with what's said. To me, though, the basic, blocking and tackling, to make sure that's uniformly done. Again, and I think AI, we have no idea what things are going to look like in 20 years. Currently, my feeling is that the rudimentary AI we're using can take care of that basic screening. I just always think there has to then be the human who makes the final decision, and especially the exceptions to the rule. I'm bothered by the way algorithms spit out the way you ought to do things, and it's right 95% of the time, and it makes sure it's done 95% of the time. But 5% of the time, there's reasons for exceptions to the rule, and AI doesn't handle that very well right now. And I think that's where the humans have to come in and differentiated. Our sepsis program, which works off of a type of rudimentary AI, is terrific at early warning and early identification. It's poor at then getting very specific. It's very good at being sensitive, but it's poor at being specific and making a final decision. This is someone who should treat and not treat. And I think that the human layer has to be in there, and I don't think we quite understand how we're going to do that with AI yet. And this is all predicated on the fact that who knows what AI will look like in 20 years.
Absolutely. Meg, do we have time for questions?
How about
2
2 questions?
questions? Okay. Please?
How do you see telemedicine playing a role in pediatrics, especially in rural areas where I'm from, where all of our kiddos are going to be sent to Duke or UNC or somewhere like that?
I'll just mention, we recently put a pediatric ER program in place, in the sense that we had the pediatric ER specialists, and they consult to many of our, not just rural, very small ERs, but even some of our larger size ERs that don't have the pediatric specialists there. We've set up a program where we're consulting to them as a pediatric specialist, and in certain circumstances, take over and manage those patients completely, even in terms of getting them ready for transfer if that's what's actually needed. It's a relatively new program, 1.5 years in place. It seems to be very successful and welcomed by the facilities.
Anybody else have a view on this?
Yeah, in 1994, we had a pediatric telemedicine program at the University of New Mexico, where we provided ENT services, basic emergency room services, but it was always with the expectation, and this again is my bias, that it expedited transfer of those patients to the tertiary facility quickly, because we recognized that in order to deliver high quality pediatric care, they needed to get to the point of service as quickly as possible. So I think this is my bias, as long as we're implementing pediatric telemedicine with the understanding that the patient is going to get to the appropriate level of care versus staying in a rural community, I'm all for it. And I think that will be sort of the growing trend.
Any thoughts? Another question? Yes.
Hang on 1 sec, I'll give you a mic that's working.
So thank you so much for giving such a nice presentation. I'm one of the nephrologists from New York, and I'm also the program director of the fellowship. So my job is more on looking into the innovative models for medical educations. One thing I always want to ask about the acute model. So we know about the pre-acute model, keeping patients at home, and they can connect with their doctors, work for them. But in the acute care setting, when the patients are in the hospital and they're not visualizing the doctor, they're basically visualizing the doctor through technology. The biggest factor that comes is the bond of doctor-patient relationship. So how is telemedicine addressing that? And with the value-based medicine, most of the reimbursements that the hospital is getting is based on the patient experience. So how is the telemedicine or SOC is addressing that issue, and how are you measuring it or gauging it, the patient satisfaction?
So let me start, and I'd love views from others on it. We've looked at this pretty closely, right? Let's imagine a patient having an active stroke. What our experience is, and what providers and patients are telling us, is they're thankful to have somebody qualified that is going to be able to take care of them in the acute state that they're in. So whether it's telemedicine or a live person, for stroke care, they just want a qualified individual taking care of them. When we talk about behavioral health, I heard something interesting from some of our psychiatrists and also from some behavioral health leaders in the marketplace. When people are coming in with behavioral health issues in a hospital setting, there's at times a reluctance to share openly with the clinician on the other side. There's that reluctance with that person you're sitting across from to share what is truly disturbing you. But there's a disassociation of that relationship when you're using a telehealth model, and we actually find that patients will share more openly with a remote clinician that may be on a video. So it's anecdotal, right? but we have heard those two specific things related to telemedicine, but I'd like to open it up to the group to get your thoughts on that question.
I just have just a short anecdote. Before I actually joined the Sound Telemedicine, I had an opportunity to visit one of our telemedicine hospitalist programs and got to see how the system worked. And I found this very moving. It was before I had even officially taken the job. And there was an elderly woman who was in the emergency department, and she was being admitted by one of our telenocturnists, and they brought the cart into the room. And during that process, her son came out of the room, and he was just taking a phone call, talking to the family, and he said, "She's in with the doctor." And it was the video cart, but that was the family's answer. She's in with the doctor, and I just found that before I had even actually started to be this incredibly compelling and heart confidence building step. Just she's in with the doctor, and she was.
Dr. Veremaks?
So over the last 10 years, I've had the burden of being responsible for tele-intensivists, telehospitalists, teleneurologists, and so that means all the complaints come to me. Rarely have I had a quality of care issue. Almost all the complaints are interpersonal communication issues. And what I would say to you is that people are people, and there are some very good communicators who everyone knows and is on a first name basis with at the hospitals, and they do well with the patients, and the interaction goes wonderfully. And then there are those people who have poor communication skills, and they're the ones who it doesn't work out for one reason or another. I would agree with you that in things like stroke and the like, most people are focused. They want good care, and if the guy's a jerk, that's okay as long as I get good care. But ultimately, it comes down to interpersonal communications. I'm bothered by, I actually made a remark to someone. I had an archaic phone until only about a year ago, and people used to comment on it. And I'd say, well, I use this phone to talk to people. And it's amazing how often the response I get is, who talks to anyone anymore? You just text back and forth. If our telemedicine ends up being just texting back and forth, I think we're going to run into dissatisfaction. I think if we try to maintain the relationships, and gosh knows the technology is making it easy to actually have those kinds of human interactions, if we maintain that kind of communication with people, I think it'll go well, and I think it will be accepted.
So, Dr. Kestner, I want to ask you this, but also add to it, to the question that was asked. Is this a generational issue also?
Yeah, so I'm going to use a personal story. My mother has congestive heart failure and bad renal function, and she's at a skilled nursing facility. She's in and out of the hospital, had been in and out of the hospital before she went to a skilled nursing facility quite frequently, and has a relationship with her nephrologist. But right now, her relationship with her nephrologist requires somebody in the family to go back to Michigan, pack her up in a car, and have the nephrologist tell her that her creatinine is unchanged from the last time, right? And so when we talk about patient engagement, I think if they're not alienating my mother, they're certainly alienating the rest of the family, right? By the process that we have for delivery of care. It would be far better if she was able to have a telemedicine visit at the skilled nursing facility and just say, hey, Jan, your creatinine is still what it was 6 months ago or 3 months ago. But instead, we're in this insidious habit of the way in which we deliver care, which requires the patient to see the physician face to face. And that's the way everyone gets reimbursed. That's the way that's the way physicians make their living. That's the way they cover their costs. So I would implore you, in teaching the next generation of physicians, to embrace telehealth and to leverage that in their relationships with their patients. It's what I'm going to expect. It's what my kids are going to expect. I think it's what all of us expect in the room, and we don't necessarily see a value in going to the office or a value in seeing a face-to-face visit if we know we're being cared for well.
Well, look, I'd love for you to help me thanking this group. It's hard to get these type of individuals together on one panel, and we really appreciate your time. Thank you.